Good evening. I'm Dr. Arin Sunny, Senior Resident working at Jubilee Mission Medical College, Thrissur in Kerala. And it is my privilege today to be talking on bridging confusion with clarity on effective communication in the ED. I will be talking mainly on vulnerabilities in communication, that is factors affecting communication in the ED, and also some effective strategies to combat the same. In the words of George Bernard Shaw, the single biggest problem in communication is the illusion that it has taken place. And for us emergency physicians, troubles in communication are more often spoken about than solved or practiced. Communication in the ED takes place between healthcare staff, doctors to patients, and to patients' care. And there are many modes of communication that are employed in the ED, with verbal and face-to-face communication being the most common of them. There are other modes like telephonic communication, written messages, whiteboard communication, and also computers can be used to communicate to patients. Why is effective communication important? It leads to better patient experience. Clinicians are also more satisfied when they have communicated well. Good communication between doctors, nursing staff, admin staff will also go a long way in reducing work errors. We know times have changed. Gone are the times when doctors were worshipped. Today, litigations against doctors, violence in the ED, violence against doctors is on the rise. And we do have to admit that many times our ineffective communication skills can also contribute to the same. The struggle for us is that there are no universal guidelines to effective communication in the ED. It is patient-tailored and it is situation-tailored. Statistics claim that 89% of an emergency physician's time is involved in communication, and nearly 42 communication events per person per hour takes place in the ED, with 30% of these being classified as interruptions and 10% of them as in two or more concurrent conversations. 70% of the sentinel events reported in the ED involved communication problems. These are all statistics that have come out in journals in emergency. So we do admit we have a problem. So let's look at a few factors at what may be contributing to our problem. The very nature of the ED is itself a factor. It is the only place in the hospital where unbounded care takes place. It is the only infinitely expansible part of the hospital. Any number of patients can be taken in, admitted, and held for a period of time. We all admit that the ED is not exactly the most organized place at all times. It can be chaotic at times with multiple simultaneous patients coming in and with varied presentations. The pattern of ED working also with shift patterns and handovers can also lead to compromised continuity in communication. One physician may communicate something in a shift which may not be known to the physician in the next upcoming shift. This is the ED is a resource-cramped area. This is something we've all been experiencing in the past few years. Staff shortages, there are resource constraints with a lack of ventilators, a lack of oxygen supply. These are all issues that we have been facing in the past few months or years. Our nature of work, the ED physician's nature of work, is also another factor that adds to the problem. We are coerced to handle chaos. As I said earlier, multiple varied simultaneous presentations are thrown into our hands. We are forced to look at multiple sick patients at the same time. What also adds to the problem is the fact that many of these patients that we see we see for the first time. It is our first encounter with these patients, so we have very little knowledge of their past presentations or their past condition. Many countries around the world have already enforced 4-hour windows or 6-hour windows. So there are also time constraints on an ED physician where he's constrained to take care of a patient and shift the patient within this window of time. We all do agree that there is no formal training on effective communication skills during our residency programs, either during our UG or our PG training period. Also, the factor that that multiple strata of doctors work in the ED, junior residents work under ED physicians, house surgeons work under ED physicians, and many a times their communication with the bystanders or with the patient may go unsupervised. What also adds to the fact is that patients and bystanders may come in with false knowledge or with false expectations. Many of them come in with the expectation that they can see early and leave early. Many of them come with the expectation that they will be seen on a first come, first served basis. Also, the ED is a very emotionally charged place for them. Many of them see their loved ones in the most worst states of their life. So what is the solution to the problem that we have at hand? We do know that communication not only involves the words that we say, but it also involves our body language, the tone that we speak in, the attitude that we project to the patient. So the first thing, smile. I really do not know that with the N95 mask that we have on now, if a smile will go a long way, but I do think that a smile will reflect through the mask. Our attitude will definitely reflect beyond the PP that we wear. A compassionate attitude, a non-judgmental attitude will go a long way. The body language that we hold, having a confident body language will also help. The general dictum in effective communication is said to be the 7-38-55 rule, where only 7% of what we say in words is effectively taken up by the patient, so or the bystander, so make the most of what you say. When it comes to words that we say, the verbal communication that we have with patients, there are 5 dimensions to effective communication that physicians themselves have identified, which is efficiency, clarity or accuracy, relevance, comprehension, and rapport. I don't think I do have to explain on each dimension in detail. They are clear from themselves, from the words. So coming to the most common mode of communication that is utilized in the ED, the verbal or the face-to-face mode. How can we improve on the same? So these are just a few tips to improve on the same. Always introduce yourself when you meet a patient. Listen actively. Listen to what they have to say with the least interruptions. Ask open-ended questions where the patient can answer without a yes or a no, or a true or a false sort of a situation, where they can explain in detail what they're going through. Always it helps in knowing who you're communicating with, the relatives or the bystanders, their names. If you can address them by names, it would help. How they're related to the patient. Some may not at all be related to the patient, so knowing who you're communicating with helps. If needed, while talking to the patient, take notes, because it only goes to show that you are paying attention, that you are actively interested and involved in this patient. After the patient has spoken, when it is time for you to speak, always talk to the point and in an assertive and an active voice. They need to know that you are confident, that you are at command. Patients need to feel informed. They need to know the care pathway that you're going to follow for them, what their present condition is, what their treatment plan, what their intended treatment plan is. And it always helps in giving them a heads up in terms of their waiting times. How much time a lab result will take to come in, how much time a radiological investigation will get to be done. It helps when they know how much time they have to wait. If you feel you're not in the right frame of mind while talking to a patient or a bystander, it it is always helpful to take a break, go refresh yourself, come back, and then talk to them. When breaking bad news or when talking to the bystanders of a critically ill patient, ensure privacy, ensure that you take them to a private space and then you talk to them. We all know this mnemonic, so I'm not going to go through this in detail, where this is a mnemonic that is used to give us a small nitty-gritty on how to talk with the kin of those who are critically ill or those who are dead. This is something that has been said to be very effective when followed in the ED, a whiteboard or a poster explaining the triage process, how you will be triaged to each area and which areas are given importance in the ED. If that could be communicated on a whiteboard or a poster, it would help. Also, the waiting times that are expected in an ED, the current patient load in the ED, the bed status, not only in the ED, also of the ICUs in the hospital, also the available services when explained or written down on a whiteboard is said to effectively manage chaos in the ED. These are other effective strategies that has been seen. One, using media or announcements in the waiting rooms to bystanders regarding the same, regarding waiting times, regarding the triage process in the ED, regarding the patient load in the ED could be helpful. Also, you could use sound absorbing infrastructure or use other tips in the ED to reduce the ambient noise, because many a times we're seen to having to raise our voice to talk to patients and bystanders. It is high time that we include training programs in our residency in both UG and PG curriculum to effectively communicate to patients. And also this is something that has been, visual signaling is something that has been said that can be implemented in the future, where a patient can be given something, a sort of a light signal or some sort of a cue where they can signal to a patient or to a doctor or to a nursing staff when they are in need, when they need to communicate to the doctor or so on. Written communication is especially important in communication between healthcare staff. So all said and done, it is not only what you communicate, but you also need to document. You need to document who you spoke to, the need, how they're related to the patient, what and why. What are you planning to do with the patient, the care plan, the treatment strategy, and also why have you chosen that treatment strategy or that care plan in the patient. And also always document how the patient's bystanders or the patient has responded to your care plan or your treatment strategies. Many a times we may explain intensive care and aggressive management to bystanders. They may not choose the same for varied reasons, for palliative reasons and so on. It is always helpful to document the same in your ED sheet. So in summary, we do agree effective communication is important in the ED. We looked at the major amount of events that were reported in the ED involved problems in communication, and we do agree that effective communication is an art to be learned. So I conclude with the words of Mark Sanborn in Teamwork: silence isn't golden, it's deadly. Thank you.